On behalf of the Patient Safety Authority, I'd like to welcome you to this webinar titled Keys to Investigation, How to Determine the Type of Investigation. My name is Bob Yanish. I'll be your moderator for this program as well as one of the speakers. And as always, we welcome any comments or questions, and all materials are provided for your educational use. Now I'd like to introduce our speakers for the webinar. My name is Bob Yanish. I'm a patient safety advisor with the Patient Safety Authority. I interact with patient safety officers and other various healthcare staff to identify safety hazards and risks, as well as reduce patient harm. Also joining us today is Kelly Gibson. Kelly is a program manager with the Patient Safety Authority. In this role, she has been involved with initiatives to decrease patient harm, such as education, webinar development, consultation, on-site observations, and article development and incorporation of the patient voice into the PSA's work. Kelly, I'll now turn the program over to you.
All right, thank you, Bob. Good afternoon, everybody. We welcome you to this webinar. This is the second webinar in the Keys to Investigation Keystone. Just to give you kind of an overview, some of you may have been on the webinar last month for reporting. Some of you may not have been. The part of the goal for this Keystone is to help and provide facilities with knowledge and skills of the investigative process, recognizing that not all investigations are just for those high harm level events, and what are the breakdown and the components of it, and giving you these skills to develop your professional development. We're using these webinars to gear up towards, at the end and in the spring of next year, workshops. There'll be 3 workshops where you can actually apply these tools and resources that we're giving you during the investigation or these webinars. So we'll actually get a chance to practice those skills. We're really going to look into today apparent cause analysis, root cause analysis, and common cause analysis, looking at the similarities and differences and when you might utilize these different types of investigations. All of our presentations or the education that we do at the Patient Safety Authority, we always refer back to MCARE because this is legislation that really has created us. And when we talk about investigations, looking at the component that speaks to this, a facility must investigate all reports, take action if needed, and share results with the Patient Safety Committee. So even though we typically think of, okay, well, maybe a high harm event or certainly sentinel event, we need to do XYZ, we have to recognize that there are those, maybe we'll say that the events that we see every day that either don't cause harm or don't even reach the patient, that we have opportunities to learn about those events and prevent those things from happening, because the next time that event occurs, it could potentially lead to patient harm. Discussed in last month's webinar, event types are definitely something that might make you think that, oh, well, if I have this type of event, I need to do this type of investigation. But recognize we're not limited by those. Certainly, if you're a Joint Commission facility, you probably recognize that, well, we have to do root cause analyses related to sentinel events. But also keep in mind that there's learning opportunities that we have in those events that don't reach the patient, or if they do reach the patient and don't cause harm, we still have lots of opportunity to learn from those events as well. And there is a potential to do an investigation on those events. So you learn about a patient safety event. Well, even where do you learn about that event? I know last month we talked about some of those in the reporting and how those come through your internal reporting systems, but also recognize that there are other ways of identifying patient safety events. We can point back to, and Shelley has shared in the chat, the link to our Outside the Box webinar series. So what are other ways of identifying potential patient safety events without using your internal reporting system? So if you have a chance and did not participate on those webinars, feel free to look at those as other ways to identify events. So you get these events and then you think, okay, what's next? Do I need to do a deep dive or not? Investigation is looking at a process for reporting, tracking, investigating incidents. It's broken down into 2 steps, but also recognize that it's also encompassing the resolution and documentation as well. So we investigate, we gather information. There's multiple ways to do that, but then we do the deeper event analysis after you gather the information. There's a lot of different ways to gather information. We'll touch on some of those, but subsequent webinars will do a little bit of a deeper dive into that. But typically when you get an event, you'll start probably asking questions of either those individuals that were involved in the actual event, depending on your facility and your operations. If you're from an ambulatory surgery center, you might actually start talking to those that are actually involved with the event. If you're from a larger hospital, probably like a couple hundred beds, more than likely you can't get to those individuals. You'll be starting to reach out maybe to a department manager that's involved with the event. From that information that you start to obtain, I know personally, I would always develop some sort of event timeline, starting to look at the sequence of the events that occurred, because that puts into place a little bit more of the cause and effect. Whatever works for you and your organization is what you can use. It's not that a one size fits all in this scenario, but what works best for you to gather the information and help you start to, hey, is this going to be something that I need to do a deeper dive on? Use tools that work best for you, and you're going to start to want to identify the gaps in the process. As you start to think about, does this require a deeper analysis? Think about the scope. What is within your control? Equipment may or may not be within your control. We certainly, as healthcare organizations, don't have control over the manufacturing, but do we have control over the preventive maintenance, making sure we're up to date with stuff if it's software? So things like that. We certainly have systems within our control, the processes. What have we established as the process for a certain process? So things like that. If you're still not sure if this event needs to have this kind of deep dive and analysis, consider using a risk matrix. And there are multiple versions of these available. If you look online, you can easily search for them. But this looks at, say, the frequency and the severity. How often is this event likely to happen? The more frequent the event, the further up the rows that you move. How severe is the outcome? Is the severity of outcome potentially catastrophic versus minor? So the more, the higher level harm, you're going to see moving to the left. As you get to the top left corner, of course, the more likely you would want to move to doing a deeper dive or do a root cause analysis. Whereas if you're down in the right-hand corner, the bottom right-hand corner, you're less likely to say, hey, maybe don't need to get involved with that as deep. Or maybe I'll just trend it and keep an eye on it. Here's another example of a different, this was by Anthony Scott Brown. But this uses that let's say the light methodology, but using the colors also to kind of signify significance. So again, top left corner, you're probably going to want to maybe do that deeper dive on the event. Whereas, hey, bottom right corner is not so bad. So we have a lot of skills. We talked about, we're going to look into 3 different types of analysis, but also, although this is about event investigation, we're also going to touch at the very end about a proactive risk assessment, because if we have the opportunity to learn without a patient being harmed, we should certainly take advantage of that. So let's look at apparent cause analysis. Some will refer to this as a mini RCA. This is a more limited investigation of an event with the purpose of identifying actions to address problems and immediate concerns, and also to collect information that aids in identification of organizational trends. This is not doing quite the deep dive. This is looking at, okay, what was the event that occurred? Root cause analysis goes a little further and goes a little deeper. So apparent cause is going to be more limited. Typically, you're looking at maybe just one or two departments, not necessarily multiples. It's not as resource intensive and resource heavy. Typically, these events are not causing the significant harm that, say, you would see with doing a root cause analysis. So the individuals that facilitate these are typically have some training, but maybe not quite as the depth and the breadth of root cause analysis. In your references, I think it's the 7th reference. It's called Apparent Cause Analysis, a Safety Tool. Children's National Hospital in DC developed an algorithm that really looked at kind of how to triage or what kind of events require an apparent cause analysis. So developing a standard of work or criteria for when to perform what kind of analysis might be helpful. And so if you want to look at what they developed as a reference, that might be helpful. Moving into root cause analysis. Again, this is a little bit of a deeper dive. So we talked about an apparent cause, looking at the why did the event or how did the event happen. But this goes into, well, why did that event occur? Why did what happened actually occur? So this is digging a little deeper to determine that root cause. So making sure we get to the tap root, that main thing that contributed to this. This is also looking at those underlying and contributing factors. I think probably if any of you have been involved with root cause analysis and looking into the specifics of it, you know that it does have the background in high reliability industry, looking at nuclear engineering, looking at aviation, those kinds of industries. I know I have participated on a course that was presented by the military. I think it was somebody from the Army that talked about root cause analysis and had some great insight about the specifics of it. When should we do a root cause analysis? Again, typically you'll see these being done with those higher harm events. However, you can still do them based on maybe it's administration or leadership in your organization want to kind of do a deep dive into something. Maybe it's just a big multidisciplinary, very complex process where the outcome for it has the potential for catastrophic events. Could it occur again? We're certainly going to focus on systems. We're not focusing on individuals with root cause analysis. You always want to make sure you're investigating what you're trying to prevent. It's easy to get scope creep during these. It's easy to get down additional rabbit holes that aren't necessarily related to the event. As a facilitator, if you are facilitating a root cause, it's our duty then, our job, to kind of keep everybody on target, stay on track, and avoiding those rabbit holes, because it's easy to get caught up in some other things that aren't necessarily contributory to the event. Again, what is within our control? What is preventable? Who participates in the root cause analysis? You might have subject experts, leadership. Leadership is, and we'll touch on this again later, but they are great to be involved to prioritize, but also remove the barriers. Having those involved in the event, the ones that were actually participatory or involved with the event that occurred. And there's kind of two schools of thought related to that. Maybe they participate in the actual RCA. Maybe they don't, because they bring a lot of bias. It's sometimes very difficult for them to get through in some scenarios. I've been involved in root cause analyses where individuals are crying and it's tough for them to actually contribute. I've heard some people say, well, yeah, they didn't participate, they didn't say anything. Well, when you're sitting there crying, it's really hard to provide insight as to what happened. Some cases, patient involvement. Have you ever been involved in a root cause analysis that involves patients? I've been involved with, I can speak to two where one case scenario, it was great to have the patient's perspective, the patient and the family, actually, because it was related to, I think, medications post-discharge. What was their understanding at discharge? Did they get the education they needed? So they provided kind of a missing piece to the puzzle. Whereas if it's an event that really they're not actively involved in, maybe it's a wrong site surgery or retained surgical item, are they able to provide insight about what was going on in the OR at the time? I've I know in some scenarios that they remove name badges during root cause analysis because that kind of levels the playing field. That perceived hierarchy or actual hierarchy can really set a tone sometimes of the individuals that are participating in that root cause analysis. So some people recommend putting their name badges in baskets so that kind of everybody's on that same field. That being said, I participated with a CNO who said she would stay quiet during an RCA because she wanted the people at the front line to participate, and she felt that if she spoke up, that individual would kind of shut down the conversation from the other individuals. At the same time, also be aware of your nonverbals. I've been involved with root cause analysis where after the fact, I had people coming to me as we talked about how did this go? What did you think? And they said that the nonverbal of a leader in the organization sitting there kind of looking down, staring over the glasses, kind of with this flat affect, created a demeanor that people were hesitant to speak up. If you have new staff involved, how does that work? Are they prepared? Are they feeling comfortable to speak up? Do we need to prepare them beforehand before going into the RCA? Again, there's a lot of things to keep in mind, and it's not always one size fits all. Does somebody coming to the RCA wearing a suit and tie shut down communication and conversation from others? So there's a lot of things to be cognizant of. Literature review, again, that's something that where do we bring in? What's the current recommendations of practice? What do professional organizations recommend? So thorough and credible. Considerations, certainly there's a bunch of questions that we can be asking. Determine what led to the event. Tools. Not that you have to use one particular tool or another, but it might help organize you and kind of make sure that you're, I'll say, checking off the boxes, making sure that you're hitting all the steps that you need to. Shelley put into the chat box some of our root cause analysis resources that will take you to the main page that lists out all the tools. The very first one is the tool that kind of does the whole overview and kind of guides you through step by step. You don't have to use the tools that we've established from the Patient Safety Authority. If there's something else that works best for you, that's fine, as long as it helps guide you in your process. Using flowcharts, timelines, whatever tools, again, work best for you. I know I don't like fishbone diagrams, but I love using other kinds of flowcharts. I talked about timelines earlier. So what works best for you is what is the right tool to use. And again, it's looking at this, what normally happens versus what should happen, finding that discrepancy, because there's a lot of times when I enjoying just culture education over the years, I would ask people, how many policies do you operate under on a daily basis? And I had so many people laugh at me over the years, and they really did try to count, but they had no idea, because you have sometimes departmental, you have organization, you have a whole system. There's various. Do you know every single word of every single policy? Probably not. So there's what usually happen, there's what should happen is what's stated in policy, but what actually happens because we cut corners and those kinds of things. So there's usually some degree of discrepancy and identification of them. What are the next steps when you're going through RCA? Certainly developing the action plan. How many of you have ever, if you participated in an RCA, have you walked out and you have no idea what happened? Develop some sort of monitoring or process to make sure that those actions we talk about or determine, it might be that those actions even need to go to other committees for review, depending on your organizational structure. But also then, if they don't need to go, like, how do we know they're implemented? How do we know they're effective and working? So also reporting those findings, what happened at the RCA, the potential action items, reporting them back through leadership, having that kind of full circle of ensuring that there's eyes on this and what's happening. Again, leadership is so important because it prioritizes, as well as they have the ability to help remove barriers, and certainly reporting back to your patient safety committee. At this time, I will turn the presentation over to Bob.
Thanks, Kelly. I appreciate it. Um, we've gone over the ACA and the RCA, so let's delve into a third analysis. This is called the common cause analysis. The common cause analysis is really a process used to identify underlying causes of errors and contributing factors related to the event and to design an action plan to prevent the recurrence of this event. We're basically identifying a theme and we're establishing a timeline to be able to do this. Really what the common cause analysis does is we're looking at multiple events over time and looking for the common cause in those events. Think about, we're trying to correct minor issues before an event occurs, and we're trying to facilitate broad, far-reaching improvements. Think about a specific unit. We might be talking about a unit. We might be talking about, some type of event. Let's say falls, for example, might be one good one. So the themes. We're looking at, you might be looking at location events. Maybe you did an RCA, and you notice that there were certain units that were having some issues with falls. We might want to just focus on a certain unit. Maybe it's equipment. Maybe Biomed. We found out from Biomed that they're having some issues with certain equipment. Medication ordering issues is another good one. Patient characteristics. Maybe time of day. We're starting to see these events. Let's say that you looked at falls throughout your facility and you saw that there were certain times of the day that you had an increase in falls. Might be something where you want to look at staffing. Is our staffing adequate for evening shifts, night shifts? And then we want to look at the severity and probability of each of these. So doing this, we want to make good use of our time. So we want to identify a part of the process where the patients are most at risk. I mean, goodness, we only have so many hours in the day. We can't do root cause analysis on everything. We can't do a common cause analysis on everything. But we want to pick a process where we can get the most bang for the buck. What's causing the highest percentage of events? What's creating the greatest risks? What focus will yield the most benefits? For example, if 60% of the falls were related in your facility to toileting, you might want to focus on toileting issues. You can use flow diagrams to help to narrow down this focus as well. The thing here is to establish these priorities based on your data and findings. So next steps for this. Probably want to start by creating a flow diagram. That's what works best for me. And as Kelly explained earlier, there's no right or wrong way to do any of these. What works for you? But I can tell you that myself, I live and die by the Post-it notes. I love making my own, creating a flow diagram by using Post-it notes. As I go further in my investigation and I look at and I hear back from some of our facilities or from some of our units, I may want to change things around. We want to focus on these commonalities really across the process. If we're looking at falls across a nursing unit and most are related to toileting, then the team might want to focus on that toileting. If it's related to something else, we want to focus on that area. But we need to get out there and talk to staff to figure out exactly what is going on. So looking at the three types, don't get into weeds about what type of analysis we're going to do. We can't always do a full-blown root cause analysis. We're looking at an apparent cause versus root cause versus common cause. I mean, apparent and common cause, we're only looking at maybe a few cases or trending over time where, the root cause, we're looking at higher harm types for the risk matrix that Kelly spoke of a little earlier. When we're talking about root cause analysis, we're talking about a much larger team. We're talking about a diversified team, involving many disciplines, possibly even some content matter or subject matter experts. So it depends on the event itself, and it's something that we stay off and at the Patient Safety Authority. It really all depends. We don't know, your facility or what's going on as far as certain events that are occurring. That's really going to be up to you to make that decision as to, the breadth and depth of the issues you're reviewing. The similarities, we want to make sure we're looking beyond the obvious. We're using similar tools, similar methodologies. The whole idea here is the prevention of future events. We're trying to be proactive. We're trying to get to safe patient care, and we all want to do that. But we're looking into the data itself because there are times that things are right there in front of us that we just don't see. And by getting the group together and doing these types of analyses, it gives us a better picture of what's actually happening on the floors. Again, when we ask which analysis do I use, and we hear this a lot. Again, it depends. Some facilities actually establish criteria. They may have their own policies as to which type of analysis they're going to do for which type of events that are going on. You can create an algorithm, some type of guidelines. Depends on your facility, what works for you, the staffing levels that you have, and your tools. Again, what works for me may not work for you. I talked about the sticky notes. I sort of live and die by the sticky notes. They work well for me because it's easy. Some people use a whiteboard. Some like cause and effects diagrams, fishbone diagrams. Make sure, chart reviews are usually involved in most of the investigations that we do. But sometimes we need to get out of that chart and sort of get onto the floor. Talk to staff. See exactly what's happening. Observe. Take some time if you can and observe. Let's say it's a medication issue. You may want to go on a medication run with that, or pass medications with staff. See exactly what their processes are. Because too many times we sort of get this picture in our head as to the way that we think it occurs. And it may be that way on the unit that I used to work on, but a different unit may actually have their own process. It's what works for them. So really you need to sometimes get out behind the desk, get into the units, and actually talk to the staff involved. Don't get yourself pigeonholed into only talking to maybe unit managers. We're talking frontline staff. When we're talking, let's say patient falls. I've talked to staff whenever I've worked in other positions. If I wanted to find out what was going on inside of a room, I usually spoke to the housekeepers. They know everything about what's going on inside of those rooms. But how often do we actually include ancillary staff in our interviews? Sometimes not at all. But they're looking at things from a different set of eyes, from a different focus, and there may be something that they observe that we don't see. They spend a lot of time with patients. So when you're looking at something like, falls or for toileting or whatever it might be, they may be able to cue you in there. So don't pigeonhole yourself into just one type of interview if you're going to do interviews or observations. So other considerations. I guess number one on the list that I have here is timeliness. If you're going to do an investigation, you're going to do some type of analysis, try to schedule it as soon as possible after the event. If you wait too long, some of the details the staff are going to give you are going to fade. I can tell you that I usually tell people I forget what I had for breakfast yesterday. I mean, goodness, when you're taking care of that many staff, that many patients at a time, our staff are very busy. It's sometimes tough to forget. If we schedule an analysis a month out, there's a really highly likelihood that staff are not going to remember everything that happened or all the details. So we want to get out there as soon as possible. We may not be able to schedule the analysis right away, but at least we can get started with some of the interviews or so. We also want to prioritize. Our time is very valuable. So prioritize who we can talk to, when we want to talk to them, what type of events we want to include here. And one other thing I really want to stick with here is leadership support. It's very, very important to have leadership support when you're doing these analyses. They can open doors that you may not be able to. Yes, as Kelly was speaking of earlier, just being there can help. Sometimes when administration or someone from leadership actually sits in, there are times when it actually quiets the room. But it's very important to have administrative leadership involved. I know in the past I've had administrators that have actually sat in, taken an active part in root cause analyses or other analyses that we've done. Like I said, it's really opened up some doors for our facility, as well as whenever we go to actually put action plans in place, they can actually open up some purse strings to get you maybe some monetary support for changes that may be needed. Plus, they can ensure that things are followed up. So I think it's very important to get leadership involved. Let's just touch for a second on good versus bad investigations. Again, the good investigations are asking what? We're peeling back the onion. We're asking the what, the why questions over and over. We want to get to the center as to what is the root cause? What's going on here? When we look at bad investigations, we sort of look at and sort of point the finger as to who did what. That's not our goal here. We're not pointing fingers. We're not asking who did it. We want to know what happened and what we can do to fix it. We want to make system improvements, but we can't make system improvements if we don't know. System improvements are definitely our goal. Sometimes forcing functions, other times just ensuring that we just change the way that we do things to prevent future events. What we don't want to see are the lackadaisical, oh, we're going to do education. Well, everyone does education. I mean, I've worked in facilities where education consisted of a sheet on the back of the break room door, and there was an answer sheet there, and everyone picked it up and they filled it out and they put it back in, and we educated all the staff. Is that really going to enact change? Probably a very small portion, but it shouldn't be a one size fits all, and we're going to educate staff for everything. So what about the proactive approach? I mean, with us here at the Patient Safety Authority, we're all about being proactive. We want to try to prevent errors from happening. Why wait till the barn's on fire if we can prevent it from happening in the first place? And one other type of analysis I want to bring up is the FMEA, or the Failure Modes and Effects Analysis. Basically, what it is a proactive risk analysis. We want to be proactive. We want to identify ways that a process or a design can fail. As Kelly spoke about earlier, highly reliable organizations do FMEAs all the time. They are always looking at near misses, and I mean, near misses are actually just a gift to a facility, because you can take that near miss. No one got harmed this time, but someone definitely could have been harmed. So what can we do to prevent that harm from ever happening? And we want to just dissect it. Why might it fail? How can we make this safer? What can we do to prevent this from happening? A couple examples on these. I take care of looking at wrong site surgeries throughout the state, and we picked I just think it's a perfect segue into this. For example, something like a consent or scheduling type errors might be something that you may want to do an FMEA on. If you have a large amount of these coming in, we might want to look to see, is it a certain physician's office that is sending these? Because these can all lead to a wrong site surgery or some type of serious event and harm to that patient. What can we do to prevent this? So, for example, here's something that was actually published in the Patient Safety Advisory many years ago. But The narrative goes as this: incorrect paperwork was identified in the pre-op during the verification process. The pre-op scheduling request from the surgeon's office states right shoulder surgery. Patient is actually scheduled to have a right knee meniscectomy. Now, this was caught. It's a good catch. That's fantastic. I applaud you for catching this. But do we maybe want to look at this to see, hey, is this actually an issue in our facility? How many of these types of scheduling errors do we notice? Is it something we can try to prevent? Can we work with our surgeons' offices to prevent these from happening in the first place? So that's a perfect example of where we can do a failure modes and effects analysis. So if the only tool you have is a hammer, you tend to see every problem as a nail. This is a famous quote by Abraham Maslow. It actually refers to a concept commonly known as the law of instrument, or Maslow's hammer. You may have heard this, and I'm sure you've probably seen this in other webinars. But it basically refers to an over-reliance on a familiar or a favorite tool. Just be careful you don't fall into this trap. You know, there are some investigative techniques that are better suited to certain events than others. You know, you can't build a house with only a hammer. You're going to need a screwdriver. You're going to need a nail gun. You're going to need many other tools. Be careful. Use the appropriate type of investigation for your situation. You don't always want to do one type of investigation. For example, you know, I've heard facilities tell me that, you know, oh, we do mini RCAs on everything. Well, is the mini RCA actually the way to handle every event? Maybe some actually do need to be a full-blown root cause analysis. But then again, you know that we can't do a full-blown root cause analysis on every event. Time is not always on our side, and we don't have the staffing to do that. So they just don't get pigeonholed is what we're trying to get across here. So again, one final thought. There's no right or wrong ways to do an investigation. It's really what works for you. We need to look at the situation itself. I know we've gone briefly over many of these today, but we're going to get into much more details as we get through the webinar series, as well as our workshops that we're planning for the beginning of next year. We hope to see you all there. So it really all just depends. So this was, you know, back in 1999, many of you probably know about something that we call sort of the Bible of patient safety. It's the first actual paper that was written on and actually looking at patient safety. It's called The Error is Human. It came out in '99 from the Institute of Medicine. And there is one quote in there that really sticks with me. A critical component of a comprehensive strategy to improve patient safety is to create an event or an environment that encourages organizations such as yours to identify errors, to evaluate the causes, and then take appropriate actions to improve performance in the future. So you want to identify errors in your facility, try to figure out, hey, what happened? What can we do? And then take appropriate actions to improve performance to ensure it doesn't happen again. We need to make sure that the environment's not punitive. You know, if you have a culture in your facility where you actually, you know, persecute, you actually don't follow up, we need to make sure it is not punitive to staff if they bring an issue to you. I mean, goodness, if you were the patient safety officer and someone came to you and said, hey, we're having an issue with this or that, and you sort of just push them off, you know, they're probably not going to come back to you again. We need to keep that door open. We want that environment there to be non-punitive. We want to be proactive. The administrators and directors, we really need to encourage reporting. You know, when you sit in your office, when I sat in my office, when I did quality and risk, you sort of tend to get this bias as to what's going out on the units by reading the events or by thinking you may know. Sometimes we actually have to get out there and talk to staff. We need to encourage them to tell us whenever there are issues. too many times what I hear is, why should I put an event in? No one ever got hurt. I don't have the time for this. Well, yeah, but we can't make the changes. We can't make administration. We can't make any area or actually work with the unit directors or even yourselves to make these changes if we don't even know what's going on in our units ourselves. So I think it's really important to encourage reporting from our staff and then not to place blame on those individuals. The event reporting allows us to take action, and the big thing here is being proactive so we can prevent harm to others. Again, try to encourage a very comfortable relation with your staff. I found that whenever I used to walk on the floor in my facility with my suit and tie, I would have people say, "Oh goodness, here comes the suits," or "Goodness, what did I do now?" Whenever you're only there, whenever bad things happen, and they're going to tend to, tie you and link you in with these bad events. We want to make sure that staff understand that we are there for them to ensure that we can make changes ahead of time. You need to let us know if you're having issues with certain equipment or certain processes. Those are things you can actually put in as incidents if you see that there are events occurring. Let us know. Tell us about it so we can make that change. You don't want to only go to talk to staff when something bad happens. So I'm going to leave you with some references here. I know that some of you have been asking for references. We'll make note of those and we'll try to get those to you. So this ends our presentation. What questions might you have? Kelly, I'll turn it over to you.
Thanks, Bob. And I know, as Bob indicated, some have been asking about one of those references. I think it's listed actually. When I mentioned the algorithm earlier about kind of, hey, when do you do an RCA? When do you do an ACA? It was more in reference to the ACA, but it's this, I think, it's the seventh one down. But keep in mind, if you scroll down and you'll find figure 1, that is the figure that'll the algorithm that I referenced. So again, it's a way to help you. It's not that you have to follow that precisely, but it might be a starting point for you to think about ways in order to kind of triage your events in your organization. Creating standard workflow or practice around that will help you kind of, so there's no surprises throughout your facility as you want to kind of move forward with one of those. The other thing, I know there was a question or clarification about slide 16. I didn't think MCARE required RCA for all serious events. That is correct. MCARE does not require root cause analysis for all serious events. That slide was a little more about thinking of different opportunities of where you might want to do RCAs. So that's kind of it. For some facilities, it might be that you focus on all your serious events. For other organizations, that might not be what is your determination. Again, that kind of almost loops back to what we were just talking about developing some standard workflow about when in your organization do you perform RCAs or other types of analyses. So again, maybe look back to that algorithm.
Kelly, I see that we have a question from Sandra in the chat. Is there a structured way to define who should be part of an RCA? Again, that really depends on your facility and the event at hand. Really shouldn't, I hate to say, but I don't like structure. Their structure has its place. But in a case like this, there may be certain people you want to have at every one of your RCAs. A patient safety officer, someone from administration, maybe the unit director involved. But I think there should be some leeway also as to, let's say that we're looking at medication events in a unit. And we have, the administrator there. We have the patient safety officer. So you may want to have, since it's a medication event, the director of pharmacy there, or someone from pharmacy, a clinical pharmacist there. You may want to have, I would highly recommend staff that actually use and actually participate in the process itself. if they're the ones that are actually passing the meds every day and they're having some issues, why would we not want them involved? Why would we want a high level discussion without in hearing from, what exactly the issues are? But think outside the box also. Maybe biomed. Maybe it's a biomedical issue. Maybe it's an equipment issue. You may need to have IT there if it's an issue with, something that they're handling. So it really depends. I hate to keep saying depends, but it does. Each facility is unique. You know that healthcare is so multifaceted, and not every event is not the same as the last. Just because you have one medication event, another may be completely different, and you may have a different set of employees there at the table. I'm just scrolling through and seeing if we have anything else. I have another question here. So it says we do a mini RCA on all of our series events in our facility. Do we also need to do an extensive RCA? Well, I hate to say the D word again, but it depends. Remember, the RCAs are performed for these cases of higher severity and likelihood. Remember the risk matrix? I sort of like a little partial to the one with the colors, because when you go towards the red, I think you get to see it's more towards a harm, and it's something that you really want to probably dive into a little deeper. But think about it. It's impossible to do a full-blown RCA on everything that we do. So yes, depends on your mini RCA. What components are there for this mini RCA? Is the mini RCA basically just the patient safety officer doing a chart review, or is it actually maybe a small group getting together to talk about this? So it depends on your facility, but I think that, like I said, in most cases, you're going to be doing some type of a preliminary review before you make that decision. And like I said, the decision may be different on every case that is there.
Bob, there's another question here. Our administrative team conducts RCAs when they feel it is needed. Should we include others on the team outside of administration? And I think, although we say it depends a lot who you should include, but it definitely needs to be beyond administration. I mean, we've talked about some of the frontline staff. We've talked about content experts. Does that mean biomed? If it's something that involves IV pumps, you probably want to have biomed. You might need pharmacy involved. So every event might lend itself to a different degree of who participates. And then even from the RCA, I talked about earlier about action items. It doesn't mean you go out of the RCA and, hey, those action items are going to be implemented. You might have to also vet them in other venues, or depending on your workflow, they might have to go to other committees for further review and before things get implemented. So yes, we should have more individuals involved, but who that is really going to depend.
Okay, I see one other question that came in, similar to what you were asked before, Cal. Are the regulations requiring the use of a certain specific analysis? Not really. There are no regulations requiring the use of one specific process. Just remember, though, that certain accrediting bodies may require you to perform a certain type of analysis. It depends on your accrediting body and what they want you to use, but there's really nothing in the regulations. And truthfully, the regulations, I think we all know that the regulations are gray to a point. And for a reason, as I said earlier, every one of these cases basically depends on, the severity of the injury. If it's a very high criticality on that scale, yeah, we might want to do a complete RCA on that, maybe an extensive RCA. But it really would depend in your facility. To answer the question, no, just make sure you check with your accrediting bodies to see what they require, because some have very specific requirements. If there are any other questions, please feel free to put them in the chat box. And as you know, your advisors are always available to you. Give us a call at any time. We are more than happy to answer any questions. That's our job. If we don't know, we'll find out for you.
Just to re-emphasize, I did post the link to that resource, the algorithm, to kind of help guide you through consideration for an analysis. So if you're interested in seeing that, that link is in the chat box.
Kendra had one other question. How can you measure the effectiveness of an RCA? We're going to go into this a little deeper in future webinars as well as the in-person, just because of time limits. I mean, we used to do some of these sessions were up to 4 hours long for root cause analyses. I mean, we should spend a lot of time on this. And like I said, we can talk about this all day. But the thing here is, I mean, for me, when you actually look at the outcome, when you have your action plan, do you see results with your action plan? I think that's where we can see the effectiveness of this. And goodness, there are a number of other things. Getting back to where you were at, think about you were asking also before about defining the team members who don't feel intimidated. I mean, it's very difficult sometimes to have an effective team if we don't have the right people at the table, and if we do not actually have if we don't have a setting that is actually going to help this process. Causal statements is another way. Kelly, can you think of anything else you want to add?
I would just add, I know there are some facilities that actually do evaluations related to their RCAs and even ask for feedback from their participants to get information back from them, just almost like in our education sessions, and we get evaluations about the effectiveness of them. So quite simply, you could do that. You could ask for feedback from individuals like that. But yeah, metrics, I was trying to think wrong site surgery we talked about earlier, or you could potentially be doing monitoring, whatever it is, that process that you put into place. Are you doing what you said you wanted to do? So is it monitoring all, I don't even know, consents right now for the components that need to be there. So doing some sort of auditing observations, those kinds of things are also valuable. See, somebody might be sharing some metrics that they look at. So as we wait for those to come in, I am going to be wrapping up since nothing else has been coming in. We want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. It looks like somebody had mentioned, as far as the metrics, the TAT to completion and recurrent events. We also reconvene the group for more significant events at a later date to review status of action plans. So great opportunities to look over what's happening. Bob, do you have anything else before we conclude?
Not really. Stay tuned to future webinars. We're going to be talking about causal statements in one of the webinars. I think that may help to answer your question. Looking at the causal statement, linking the cause itself to the effect. So that'll be coming soon in one of the future webinars. And we look forward to all of you attending future webinars in this series, as well as our workshops that are coming early next year.
Great. Thank you all for joining us. Next month, and I think it's actually next week, we will be talking about the everyday investigations. So not just all those RCAs and those deep dive analyses, but what do we do on a day-to-day basis. Thank you all for participating. This concludes our webinar.